Thank you so much. I appreciate that. Thank you all for joining us and taking your evening time to spend a little bit of educational time with us. My name is Sameh Mossayed. I am the director of the Glaucoma Division at the Gavin Herbert Eye Institute and professor of ophthalmology. I am tag teaming tonight with Dr. Andrew Smith, one of our new recruits. He's an assistant professor of ophthalmology at the Gavin Herbert Eye Institute and a glaucoma specialist. So what's going to happen is Dr. Smith is going to go through some slides to review basic concepts about what is cataracts, how do we manage them, and then we're going to talk a bit about the combination conditions of glaucoma and cataracts and how we can often address both of those problems in one surgical session. At the end of the slides and some videos, we'll have some nice videos for you all to see. We'll take your questions. So go ahead and put your questions into the chat box as you think of them. You can do them throughout the course of the slides and we'll address them at the very end, or you can save them for the end and put them in the chat box there. And so we'll be going through the chat box and removing any questions you have and hopefully addressing all of them if there is time. So without further ado, the wonderful Dr. Andrew Smith is going to take it over and educate us about cataracts and glaucoma. Dr. Smith.
Thank you so much. And it is a privilege to be here. And thank you all for attending. I'll echo that. And hope we can learn a little bit about cataracts and glaucoma. Again, my name is Andrew Smith, and it's an honor to be here with you guys, and also an honor to be part of the Gavin Herbert Eye Institute. It's a great institution. So let's get started. Let me first see if I can progress. There we go. So first we're going to talk mostly about cataracts. So what is a cataract? A cataract is a progressive clouding of the normal clear lens of your eye. And for people who have cataracts, seeing through a cloudy lens is a bit like looking through maybe like Vaseline, or like this says a frosted, fogged up window. Vision is blurry, might have some glare, and that can be very irritating. And so it's a big problem in the United States. It's the most common outpatient procedure that's performed. The number of Americans age 40 and older who are affected by cataracts are at least 20.5 million. The number is probably climbing. And the percent of Americans with cataracts that are 80 years and older is over 50%. And Medicare spends $3.5 billion, and that's also probably increasing as time goes on, as more cataracts and people with cataracts come to age, essentially. In order to understand what a cataract is, it's important to understand the anatomy of the eye. So this is an eyeball that's been cut in half. The front part of the eyeball is over here. If you see my mouse, that's the cornea. It's the clear dome that goes over the eye. It's the thing, if you were to poke your eye and go straight into your eye, that's the thing that you would hit first. And then you have the brown part of your eye that's called the iris, or the blue part. It's the colored part. And right behind that is the lens. And so when we're talking about a cataract, we're talking about this lens that's supposed to be clear, and that clear lens is able to focus the light on the back part of the retina. But as you age, or due to some certain conditions, this lens can turn a yellow, brown color or white color, and affect the ability of the lens to bend light in order to focus it on the retina. And then the retina is the red part in the back, and this yellow thing coming out of the back of the eye is the optic nerve. So the retina will capture the light signal and send it along the optic nerve to your brain so that you can see. So here's an example of a cataract. Again, right behind the colored part of the eye is a lens that's suspended. And you can see here, it's kind of a yellow-brown color. When you're looking at the front part of the eye, so this is a normal eye over here, that pupil is supposed to be black, and a cataract will live right behind it. So a really dense cataract you might see, or you might see pictures in developing countries, or even here, where you actually can see the cataract. For most of us, it will stay black, and you have to look at it on our exam. We use a microscope. It's called a slit lamp. And so these are slit lamp pictures. And so up in the left here is a cataract. You can see that it's a kind of this yellow-brown color. We call that a nuclear cataract. It's the most common. It's the very center that's turning yellow and brown. That's in comparison to this one over here. This is called a cortical cataract. It's more of the surrounding edges. That one tends to turn white. There's a posterior subcapsular cataract that lines the back. And last one's an interesting type of cataract that's not so common. It's called a Christmas tree cataract. It's kind of sporadic and looks like a Christmas tree. Now, that being said, these are all interesting examples of cataract. The nuclear cortical, and posterior subcapsular are probably the three most common, but there are plenty of different types of cataracts. There is almost more than probably we can think of right now. And so there's all different, and it depends on how dense it is and where the location is. That will tell you how much it's going to affect the vision. So symptoms one might feel as they start to develop a cataract is just blurry vision, like we talked about. It also can cause a lot of glare at night, especially when driving with those headlights coming into you. Big bright light coming into the eye can be dispersed. You'll have decreased contrast sensitivity. And then another common complaint we'll get is that the glasses prescription will change very frequently, or the glass prescription can't get exactly right. And so you'll see somebody maybe who's been to the optometrist 3 or 4 times, and the glass prescription is not right, or it was good for a couple months and then it changed. And that's a sign that the cataract's starting to come on. It's changing the prescription so quickly, or it's so dense that you can't really find a good prescription. And once you're at the point where especially when the glasses are not able to get you back to the vision that you need, that's a good sign that the cataract's probably ready for surgery. So this is something that you might see if you develop a cataract, just a general blurriness of the whole picture. And that's in contrast with different eye diseases. And we'll talk about glaucoma after we're done with cataracts, and you'll be able to distinguish between the two, what vision loss from glaucoma versus cataracts looks like. This is a couple examples of cataracts causing vision distortions. The top shows you the contrast sensitivity, so the colors just seem generally muted. And the bottom is a good example of the glare and halos that one sees at night, and that can make it extremely difficult, if not impossible, to drive, which would be a problem. There are many factors that can accelerate cataract developments, but in the end, most of it is just trying to live healthy. So as you age, that's the most common risk factor. Everyone kind of gets gray hair, and most people get a cataract as they get older. The question really is it going to become visually significant where we need to do something about it? And most people actually will. But there are other things like, poor health, diabetes can worsen cataracts, trauma, obesity. There's a strong family history, prior eye surgery, or use of corticosteroid medications, either drops in the eye or even oral medications for certain diseases, exposure to radiation, smoking, or other things that can accelerate cataract development. Now, the treatments of cataracts are basically, I think of it as 3 things. So the first is that you can do nothing about it. You can live with that vision. That cloudy lens is not causing permanent damage. I often compare it to maybe having like a dirty window that you just need to clean. And so it's not like it's causing permanent damage in the eye. So you can leave it alone if you're happy with your vision. If you're not happy with your vision and the cataract's causing problems, you can try to get an updated pair of glasses like we talked about. The updated pair of glasses will not help as much with the contrast sensitivity that's being lost, and it might not help with the glare that the cataract is causing, but it might help focus the light on the retina and get you seeing a little bit better. But if those things are not working and you're still having trouble with activities of daily living because the vision is going down, then surgery is indicated. So any significant visual impairment, either reading, driving, playing golf, watching TV, anything that bothers you, that is an indication to remove the cataract. And it is important to note that there's not really any medical treatment. There's no drop or medication you can take to remove the cataract once it's there. So again, who is a good candidate for cataract surgery? It's really, for the most part, there are some rare circumstances where you need to talk to the patient, and even if they're not ready for cataract surgery, they need to do it to protect the health of the eye. Those are quite rare. Most of it is put back on the patient, meaning that when you are ready to have cataract surgery because it's affecting your activities of daily living, that's really the time to do cataract surgery. So it's very important to have a discussion with your physician. Yeah, all physicians across medicine and ophthalmology is no different. You're always weighing risks and benefits. What's the risk of doing surgery versus the benefit of surgery? And that's a case by case, an individual by individual discussion that needs to happen with the physician to make sure that the risks are as minimal as possible and the benefit is as maximized as possible. And that's what we all at the Eye Institute and all ophthalmologists should have that goal. I mentioned, and this is maybe just a little bit early, I threw this slide in here. There are some reasons why we might push someone to do cataract surgery a little earlier, and this is an example of that. So this is the eye cut and cross section. So this is the front part of the eye, the cornea, and then this pink part is the brown part or the blue part of the eye. The color part is called the iris, and then the lens, like we said, sits right behind it. In most patients, they're in the case on the left. Everything is open, but some people, you can see this lens on the right is pushed forward, and as it pushes forward, it turns out you drain your fluid in this right in front of the iris, right in front of the brown or blue part. And if it's starting to pinch in, that might be an indication actually to take the cataract out a little bit sooner, especially if it's causing glaucoma or pressure indication. So although most of it is patient dependent, I just want to make sure that we understand there are some very rare situations where we need to push you to do cataract surgery a little bit sooner. Now cataract, excuse me, a little bit more about cataract surgery. It is one of the most compelling examples of high-tech medical innovation in developed countries. It really is quite amazing how far we've come and how good we are at cataract surgery and getting good outcomes. And we're lucky enough to be in Orange County, where a lot of the companies that have made those innovations are present, and they work with us, and we get to be involved in that kind of activity. And so we're very lucky to be in Orange County and have those opportunities. You know, and I don't hear, I was thinking about taking this slide out actually, but I actually just heard this the other day. You hear stories about cataract surgery, you know, maybe even 30, 40 years ago, where people would stay in the hospital for a couple days. Their vision would be blurry for a few months. And then even when they were recovered, they still need pretty thick glasses in order to see. And we've just come a very long way from that. Our surgeries are much shorter now. They're outpatient. You go home the same day. They take about 10 to 15 minutes. Most people have useful vision pretty quickly. Like the next day, most people can even drive to their appointments, although it typically settles in 2 or 3 days. And then now we have these intraocular lens implants, as well as the formulas to calculate the power of lenses that are so advanced that we hit our target very frequently. And that's just, it's really something that we've all benefited from, standing on the shoulders of these giants who have made so much progress in cataract surgery. It's become such a nice procedure. Okay, so now let's talk about the surgery itself. So what we want to do in cataract surgery is, this was the original cataract picture that we showed. We want to take that out, and we want to suspend a new lens in the eye that's artificial, and it's in the same spot so that it's clear and it can reflect light back onto the retina, focus on the retina so you can see. And so that's the goal of surgery. This is an example of the intraocular lens implant that we use. It has these little arms here we call haptics. And then you see through this center part, we call it the optic. Extremely small, as you can say, it's a very, very extremely small implant. It's smaller than your natural lens. And we've made a lot of progress in making these different types of lenses. The lens, once it goes in, it's permanent. It'll last your whole life. It does not need to be changed or exchanged. You can exchange it if something's a little off, but we really don't like to do that. It's a little bit harder. Once we do it once, we want to keep it in there. And like I said, luckily we've come so far as measuring the eye and with our formulas that's rarely the case. They're made from different materials, but most lenses these days are made of acrylic. We have some silicone, and not many of us are using PMMA any longer. But most lenses are made of acrylic. Again, they stay in there your whole life. The surgery itself is performed under topical anesthesia. You usually start an IV to give sedation if necessary, but often patients actually don't even need that. You are awake during the procedure, and you need to lay flat. We can do it under general anesthesia, although we prefer not to. It tends to be a quicker procedure anyway, and general anesthesia carries the risk of things in the heart and the lungs, and so we like not to do that. But if there's anyone, maybe a child or a patient who has extreme claustrophobia or any physical disabilities or mental disabilities, we occasionally do general, but that's not what we like to do. And like I mentioned, the operating time is about 10 to 15 minutes. Another interesting thing is that you don't have to come off your blood thinners. All the incisions are made through avascular structures, and so bleeding is not as much as a concern. So it's not like other surgeries where you have to come off blood thinners if you're on them. This picture on the left is kind of the general setup. I know it's two medical professionals that are demonstrating this, but it's done under a microscope. And so the surgeon sits, he has 2 foot pedals, or she has 2 foot pedals, and then the oculars that they look through. And then the patient is laying flat under the microscope. That microscope, of course, has a light, so you see a light. That's generally how it's set up. So these are all the steps of surgery, but I actually prepared a video, which should be the next slide here. So I thought it'd be interesting to just go through a quick video and just look at a live surgery. So this is just to give you a little bit of a setup. So we're sitting on the side of the patient. You can see the eyelashes are draped under here. So this is the top of the patient, and down here is the bottom of the patient. And we're sitting on the side. This is the eyeball, of course. The brown part has been dilated. You kind of see it go in and out there. That's the iris. And then this red thing in the middle is the lens. What we've done so far is we made a little incision. We've injected some numbing medication to help with the pain. And then the second thing was a little bit of jelly to keep the eye formed. And then you make a second incision that's anywhere from 2.2 to 2.75 millimeters. And that's the incision that through which the cataract is going to be removed. The step that's happening here is that you've incised the outer aspect of the cataract. We call it the capsule. And you make this circular incision. Now, the cataract has this outer capsule that we want to preserve just with a circular incision in the middle. And the reason we want to preserve it is because the new lens will sit inside that capsule. And so what we're doing right now is making a nice circle around the eye in order to access the actual cataract. Good. And once we've done that, now that that nice circle is made, we're going to inject some water around the cataract to loosen it up from that capsule. Again, we want to preserve that outer capsule so the new lens can get in there. And so this is just a lot of water going in the lens so that it can free up its attachments to that capsule. Now, I chose this video in particular because you'll see right here is if you put enough water in, the lens will stand up. So the lens just stand out. So this gives you kind of idea of like the 3D structure of the lens. So it's standing up towards us right now. And then through the main incision there, this is an ultrasound probe that goes in the eye. It has energy to it, so it uses some energy to break it into pieces. And then you use a second instrument to help navigate some of that and feed the pieces into that tip. Now there's a hole there and it's sucking out the cataract. So right now there's a couple breaks in the lens and the foot pedal is used below the patient in order to suck out the cataract. And so the cataract's coming out very nicely here. Like I said before, there's three parts of the cataract. There's the nucleus, the cortex, and then that capsular bag we're trying to preserve. So this is mostly removing the nucleus. This is the very center. All that yellow broken up piece of material is the very center of the cataract, which is what is mostly causing problems as far as people seeing goes. It's the one that's not bending the light appropriately. And so the lens is now out of the eye, and what is left are these little wispies. And these wispy parts of the cataract are called the cortex. It's the very outer shell of it that's still attached to that bag. And so this, you just change instruments to get the rest of that out. And you kind of can see that it peels off. So this is a part, where there's been a lot of activity with the patient. You have to go change instruments. So there's actually a part that sometimes you get a little break as we change instruments. So there's this last little wispy. You can kind of see it on the back side there coming out. Perfect. So the next thing we're going to do is we're going to inject the eye with jelly to blow it up to give us a lot of space. And then we put the new lens in. So this is just stabilizing the eye with that left hand there. And then there's a little injector piece. The lens goes in almost like a taco. And then as it enters the eye, it unfolds on its own. So this is an acrylic lens. You can kind of see those arms that are coming out, and the very center is a circle we call the optic. And then this is just a little stick instrument that we use to put it in the right location. And again, the right location is inside that capsular bag. And then lastly, this instrument that was previously in the eye is put back in the eye to irrigate out and aspirate out or take out all that jelly that was in the eye. And then you make sure the lens is well centered. And then the last thing that I think we should all notice is that you have these two wounds in the eye. One is where you can see where the instrument is going through, and then the other one was where that second instrument was going through. It's much smaller. And we're lucky in cataract surgery where we don't have to put a suture in these wounds. We can do what I'm doing right here, which is inject a little bit of water in it and inflate it. And if the wound is made in a way that will collapse on and on itself, then it will seal without any suture. And so you'll see that no suture is made in those wounds, that this water is able to hold it tight. And then that's the whole procedure. The lens is well centered. There's a little device here that holds open the eye that will be taken out, and the patient will go home with a clear shield and start drops. So the next thing that we need to talk about with cataract surgery is it turns out there are many different types of lenses that you can put in the eye. They all look generally the same. You can see there's some differences down here, but they can function differently. And so I want to talk to you a little bit about those lenses and the lens choices. And that's something that is a discussion between the patient and the physician about what is best. And so here are the options that are available in general, and I'm going to go through these one by one. The first is a monofocal lens. Monofocal means that the lens focuses and one distance. Most people choose to be set in the distance. That means to me like anything beyond your arm's reach. So like anything like driving or watching TV, that's all good distance vision. This lens is covered by insurance. It won't correct any astigmatism. and it won't give you any range. So like I said, just do one distance. But it should be noted that these lenses actually give you the best quality of vision, especially as far as contrast goes. And so really what the consideration with the other lenses should be is if you want to try to get out of some glasses. If you're okay wearing glasses, the monofocal lens that's covered by insurance actually gives you the best contrast and the best overall vision. You just need glasses to get it. One option that we've thought of in order to help get out of some glasses by using the monofocal lens is to do something called monovision. Monovision is where one eye is set for distance and one eye is set for up close. It's a great way to avoid paying a little bit extra. It gives you the good range and it's covered by insurance, which is nice. The downside is that some people, when their eyes are set at two different locations or two different prescriptions, essentially, they get a little bit of depth perception problems. And their brain can't mash the images well together. And so we like it as a good option, but we often save it for patients who have already shown that they can tolerate it, either with a contact lens trial, or maybe they've had LASIK and it was already set up that way. And if they like it, then we'll do it. If you haven't been able to tolerate it, then you should try a contact lens trial, meaning where you could put contact lenses in to see if you can tolerate two different distances. And if you can, it's a great option, but not everyone can. And that's very understandable. And so because of that, there are other lenses that help you see far and near. There are multifocal lenses. They do a great job at giving you multiple focal points in your vision. And that just means one for far, one for like computer, and one for up close. We term them premium or lifestyle lenses. Their downside is basically two. They're not covered by insurance, and so they're usually a little bit extra depending on where you go. And the other thing is they work by decreasing the amount of the contrast going into the eye. The other thing is they do cause a little bit of glare and halo. So they come at a little bit of a price. Most people don't mind the glare and halos, and I've noticed most people don't notice the decrease in contrast sensitivity. But where that really comes in is if you already have an eye disease such as glaucoma or macular degeneration, where you want as much light and contrast sensitivity coming into the eye, it's not really a good idea to put these lenses. We try to get the lens that gives the most light in. But if you have a very healthy eye, this is a really good option. Another aspect to the lens that we talk about is the stigmatism. A lot of people have astigmatism, and you can engrave that, just like you have glasses that fix this astigmatism, you can engrave that astigmatism into the lens essentially and fix it in that way. Unfortunately, it's also not covered by insurance, and prices again will vary depending on where you go. So we considered a premium lens. You can do the toric lens as a monofocal lens, so you get all the benefits of a monofocal and you won't get any range, or you can do the toric as the multifocal lens. And so you'll get the astigmatism correction as well as the range. It gives excellent quality of vision. You have to align it very nicely in order for it to work well. But it's a great choice, especially for those with severe astigmatism, to help you get out of some glasses. And then the last lens that's relatively newer, it's probably been around for 1 or 2 years now, is called a light adjustable lens. Basically, the difference between this lens and the other lenses is that it can change after surgery. And so what you do is you measure the eye, you put in the lens that you think is the best fit for this patient, and then afterwards you can measure how close you were to nailing your targets as far as its ability to get you out of glasses. And if it's a little bit off, then you can do this procedure that's being shown down here, where you sit at a little machine, they apply some UV light, and it will change the shape of the lens. And that's what this picture is trying to show here. You can see it's flat, and then it kind of changes the shape of the lens, and so that you can adjust the prescription a little bit. Now, these are monofocal lenses only. They don't come in the multifocal range ones. The other thing that you should know if you do this lens option is that you have to wear these special glasses to protect you against any UV exposure, because that could change the shape of the lens. So you can't be outside and be exposed to the light. And the last thing is it can be kind of expensive. We tend to save this lens option for people who have certain corneal diseases where it's hard to calculate the lens power because maybe they've had like a few LASIK treatments, or they've had RK or any kind of cornea changes in their cornea. So when you're looking at what type of lens to put in the eye, it's a discussion between the physician and the patient. If the patient is happy wearing glasses and they don't mind wearing glasses, the monofocal lens is economical. It gives you excellent vision, and that can do very well. If you want to try to get out of glasses, then you should weigh the risks and benefits with the physician. You can talk about monovision. You can talk about the multifocal lenses. But one of the big risks that every physician should be looking at is if you have any sort of disease in the eye where you need as much light into the eye, we tend to lean towards just doing the standard lens that gives you the most light into the eye. So that's going to fall into the glaucoma category. There are curveballs, which I've mentioned to doing cataract surgery, and these basically all do with the measurements, especially the first two. So when you've had LASIK, you've changed the shape of the cornea, or if you have this procedure called radial keratotomy, you change the shape of the cornea in order to help get you out of glasses when you're younger. But that change in shape makes our measurements a little bit more difficult. And so because of that needs to be taken into consideration and also discussed with the patients. But also if you wear contact lenses, that can change the shape of the eye a little bit when you're trying to measure to get that exact power of the lens. And so often we'll ask you to get out of your contact lenses for at least 2 weeks, depending on the type of contact lens. Other things that we look for are things like trauma that can make that place where the lens sits a little weak and unstable. And so that's something that should be assessed. And then Flomax, I'm going to talk about, I think, in the next slide. And then other pathologies during cataract surgery, which we're going to talk about glaucoma. As a side note, there's this phenomenon called intraoperative floppy iris syndrome. And so if you've taken any of these medications that have alpha-1 blocking, there tend to be prostate medications. They can relax your iris and it can cause it to not behave in the normal way. One, it cannot dilate as much. So that pupil through which you're trying to do the cataract surgery can be a little smaller and you have to use devices to make it bigger. Or it can just kind of be waving at you or even kind of try to come out of the wound a little bit. And so if you've taken these medications, that should be something that the physician looks at. You have a little bit higher rate of complications and it might take a little bit longer. And unfortunately, even if you've taken the medication and discontinued it, once you've taken it once, the change has already been done. And so discontinuing it doesn't really help. And so it's something that should be discussed. The last thing is there is one more innovation in cataract surgery that's been for quite a while, and that's using a laser to do the cataract surgery. How you do the laser is in most centers, you'll go to a separate room and you'll lay down on a bed and they'll dock the laser and do maybe 3 or 4 steps of the cataract surgery. You'll get out of the bed, go back into the operating bed, and you'll go into a different room and they'll complete the surgery by hand. And so it's wonderful. I mean, the femtosecond laser is precise in its incision ability. It makes that circle a perfect round circle, which is very nice. It decreases the amount of time and the amount of energy that's used in the eye, which helps patients recover more. However, something I always point out to patients is that the outcomes of the surgery are pretty similar, if not the same, as the standard way without the laser. And so it has some benefits, but I'm also a little reserved doing it. It's not covered by insurance. So it is a technological advance. It helps, but it might not help with outcomes as much as we think. Another benefit of it is if you have very low amount of astigmatism, it can treat that low amount of astigmatism. Sometimes we do it for that reason as well. So the laser is basically, I have a video. You can see it's a little different here than the cataract surgery that we just watched. We're removing the circular opening. You can see it's a perfect circle. And then under it, you see the star-shaped pattern. That's the softening that the laser has done of the lens. So it comes out a little bit easier. It's less time, less energy in the eye, and therefore a little bit nicer recovery. And so those are basically the main things. The other thing that the laser can be used, if you can see it, there's these little white marks on the top and the bottom of the eye here. And those white marks are little incisions inside the cornea to help relax some of the astigmatism. So that's another benefit that it can give. But in essence, the laser, the main thing to know about the laser is that the surgery is basically the same. It helps you do 2 or 3 steps, like I said, 3 or 4 steps. But in the end, you still stick in the same instruments, you make the same wounds, and you extract the cataract in the same way and inject the lens in the same way. And so there are patients definitely who will benefit from this, and sometimes we push people to do that. But of course, this is a discussion between you and the physician about if this is a good intervention for you or not. I'm going to move ahead to save time, but that's basically what it is. Cataract surgeries have great outcomes. 90% of patients achieve 20/40 vision or better, and complications are really infrequent, as low as 0.15%. And that's usually a drop in vision or redness. And usually if something happens, we're just adding a drop, or the recovery might be a little longer than expected. But for the most part, patients do very well. We're going to talk about more complications with glaucoma as we move on. And then another one to consider is even though you're operating in the front part of the eye, there is a risk of having a retinal tear or detachment in the back. That's something that we look for after, although it's quite rare. When you're undergoing cataract surgery, there's some medical considerations to think about. So that includes that patient should be able to lay flat. So if you have back pain, that should be discussed. There are things that we can do to help with that, but you're laying flat. We say for 30 minutes to get everything set up. Otherwise, it's a good idea to maybe put the patient under so they don't have to deal with that. Like I mentioned before, you're dealing with avascular structures, so you don't have to worry about stopping your blood thinner, and bleeding is extremely minimal, which is good. Patients with other issues for general anesthesia, like dementia, or like I said, physical or mental issues can ask for general anesthesia. And then when you perform the cataract surgery and when you measure the eye to do the cataract surgery, it is ideal to get the eye in pristine condition. And often the most common thing we see is dry eye. And so if you have dry or you feel a dry eye, before you do those measurements, we often say to put artificial tears in or lubricate the eye so that the measurements can be as good as possible. And that also helps with the healing and the outcome in the long term. For the post-op course, so what does it look like afterwards? The acuity is usually pretty good on the first day. Most people grow in their vision during the first week, the 1 to 3 day mark. You can return to light work during that first week. So if you're somebody who works and you work on a computer, you can probably return to work the next day or the day after. We just ask you don't lift anything heavy or bend over for a week. We use two to 3 drops to help control the inflammation and prevent infection. And so we give a schedule for that and make sure that that you know what to do. There's no patching of the eye required. You wear a clear shield over the first night. We ask you to wear a shield at night, but during the day, actually, it looks the eye looks relatively untouched, and you don't have to wear like a big bandage. Like we talked about, there's lots of decisions to customize it to the patient's desires and what they want out of surgery, and that's all a discussion with the physician, so you know that you get what you want. Okay, so that's all about cataract surgery. We're going to transition to a little bit about glaucoma, and then after that, we'll talk about the combined cataract and glaucoma and what to think about when you have glaucoma and we're doing cataract surgery. So really quickly, what is glaucoma? Glaucoma is a group of diseases of the optic nerve. So it's characterized by loss of function of that optic nerve and loss of the optic nerve tissue. You have in that back of your eye, you have this optic nerve that's made up of 1.2 individual nerve fibers, and they carry the signal, the light signal that touches the retina to the brain. So it's your connection from your eyeball to your brain. And glaucoma, unfortunately, results in that loss of that connection. So just as an anatomy review, this is the front part of the eye. Over here where my mouse is, the lens is what we just talked about, is right behind the color part of the eye. And then the whole red structure in the back is the retina. And this yellow structure in the very middle is the optic nerve carrying the signal. And that's what's damaged in glaucoma. The question is how is it damaged in glaucoma? Well, it's the biggest risk factor for glaucoma is pressure, and the treatment all revolves around decreasing the pressure. So as your eye pressure elevates, the optic nerve in the back incurs damage, and that can happen from a few different mechanisms, a few different ways that can happen. And so this is showing right here that fluid flows from the back part of the eye through the pupil into the front part of the eye, right in front of the colored part, and that's where it drains. And so that drain can be blocked either mechanically or with small debris or through, like I said, a variety of mechanisms, in which case the eye pressure would have to be dropped. And we'll talk about how to do that. And so this is just another way to say that the eye pressure, which is measured in the front part of the eye, is what causes the damage to the optic nerve in the back. This is a color fundus photo, or a color photo of the inside back part of the eye. The red lines are the blood vessels, the arteries and the veins. The red here is the retina. And then this yellow circle here is the optic nerve. And this is a normal healthy looking nerve. Now the nerve has this feature that we call the cup. And so this is a great picture of it here. So if you see the outer rim of this nerve is a little bit of a darker color. You can see the vessels going across it really easier. We call this the rim. It's where all the nerve fibers that we were talking about, those 1.2 million fibers, are located. And in the center is a whitish area. Now, for most people, this cup is relatively small, but in glaucoma, this cup will start to enlarge. And we call that cupping, which is a sign of glaucoma. Although there is some people who have normal cupping, so it's not diagnostic of it. It means you don't make the diagnosis based on the cupping, but it's definitely a sign of cupping. This is a great example of a side by side. So here's a normal optic nerve. You can hardly see that cup here. It's very small on this left picture. And then in the next picture over, you can start seeing the cupping. So that cup is starting to enlarge, and which means that the nerve fibers that are on the edge are starting to diminish. And then on this far right picture, this is a very severe glaucoma nerve, and you can see there's not much. This is a complete cup. Essentially, there's not much nerve fiber left in there. So that's what we're trying to prevent in glaucoma. Unfortunately, once you lose the nerve fibers, you can't get it back. And so we really work hard to bring down the eye pressure in order to stop this process so that we retain as much vision as possible. Glaucoma vision damage is different than cataract damage, or excuse me, vision loss from cataracts. And so these pictures try to show that. Basically, the vision typically damage happens in the periphery. And it can happen in spots like this, but it tends to happen to come into and the center of the vision is the very last thing to be lost. And so the reason that's important is because a lot of people don't notice that peripheral vision loss that happens. And so it's something that we have to try to catch early and test for early. So here's another example of kind of normal vision in the top left, and you can kind of see the vision starting to come in with these dark spots here, more in this bottom left picture, until you're kind of left with a central island through which you look through, and you lose some of that image. And like we talked about, unfortunately, that's permanent vision loss. You can't gain it back. So the name of the game in glaucoma is to try to preserve the vision that you have once you detect it. There are maybe 30 to 40 different types of glaucomas or different conditions that cause glaucoma. The most common is called primary open angle glaucoma, but there's also angle closure. The angle refers to the drainage system of the eye. So when we say open angle, we mean the drainage system is open, but it's just not flowing as much maybe. But angle closure means the drainage system is closed, and we need to try to mitigate that as much as possible. Glaucoma happens in little kids and it happens in adults. It can happen from medication, it can happen from trauma, it can happen after surgery. There's a lot of different variety to glaucoma. Many different risk factors contribute to the development of glaucoma, including age, family history, severe myopia, which just means you're very nearsighted, diabetes, long-term steroid use. And the prevalence is about 2 million people in the United States have glaucoma, and half of those are undiagnosed. And why that is because they don't have symptoms until it's very late in the disease. And so we work hard again to catch it as early as we can. The treatment of glaucoma is basically under 3 different categories. The first, but the treatment revolves around decreasing the eye pressure. So you can do that with drops, and there's a number of different drops to make that happen. There's a few different laser procedures that can help with the drainage system and get it to flow more. And then there's surgery. We divide the surgery into 2 groups. Basically, there are surgeries in which we try to enhance your normal drainage system to try to get the drainage system in the eye to flow more. And there are surgeries where we essentially supplement the drainage system by giving it a new pathway for fluid to escape the eye. And the reason that's important is because during cataract surgery, we tend to try to do the first. We tend to try to enhance the normal drainage system. And the name for the general category of those surgeries are called MIGS, which stands for minimally invasive glaucoma surgery. And we're gonna talk about that. Really briefly, these are tube shunt implants that go into the eye to help divert. This is giving you kind of a new drainage system. These tubes sit on the top part of the eye and they shunt fluid into the back. And here you can see the tube inside the eye. And this is a color photo of the eye with a little tube. They're very small. They work extremely well, but it's a bigger procedure. And here's another example of a tube, and a little bit beyond the scope, I think, we'll kind of get back to cataracts. But this is the last thing. This is called a trabeculectomy. So besides a tube, you can also do something called a trabeculectomy. I'm going to kind of go forward because I know we're talking more about cataracts here. But basically what you do in a trabeculectomy is you open the skin of the eye, which is this part out here, and this is on the top part, and then you make this little trap door. And then you insert the eye and you let fluid come out of that trap door. You then suture that trap door closed. And then after the surgery, you let it out a little bit at a time and try to get the flow underneath the skin of the eye as much as possible. And so this is where we're kind of making that trap door and little connection into the eye. And I'm going to skip ahead here to kind of show you the most important part here. So, or the part I think that we should understand. And so this is the surgeon tying the suture over that trap door to allow it to close so that we can control the flow outside that flap afterwards. And then the last thing I want you to see is that the skin of the eye is closed over that. So this is the conjunctiva, which is the skin of the eye. It's closed over that, and it gives us a little pocket of fluid. Details about the procedure, I think a little, again, beyond the scope of this presentation, but these two procedures, the tubes and the trabeculectomy, are bigger procedures. They work very well for glaucomas when we need them. But luckily during cataract surgery, we have the opportunity to intervene as well. And so that's what we're going to talk about next. So now trying to combine the two of glaucoma and cataract surgery. As we discussed, the lens types, multifocal lenses, we really try to avoid it in glaucoma, and that's because we want as much light going into the eye as possible. Toric lenses do not affect the light, so we can put a monofocal with astigmatism correction. Those are okay. You can even do a light adjustable lens if you want, but we really encourage monofocals to let as much light into the eye. So that's the first thing to understand when you're talking about cataract surgery and glaucoma. The other thing to think about is, unfortunately, for glaucoma patients, complications are a little bit higher. And so it's nice to be aware of that and to be able to discuss that with your physician. The pressure of the eye after surgery can spike, and the surgeon should be ready to manage some of the eye drops after surgery. The other thing is that the eyes in glaucoma can sometimes be a little bit smaller, and there's smaller space to work with, and that can cause a little bit more inflammation and prolong the recovery a little bit. Often we see cases where the pupil is not dilated as well, and we have to work on that. So again, the surgery can take a little bit longer, and again, the recovery can be a little bit longer. And then zonular weakness, the zonules are the little trampoline springs that keep the lens in its spot. And if those are weak, then the lens can either not be held in that right spot, and you have to strengthen it or put it in a new location. Or they can just be flat out damaged, and then you can't put a lens in the eye. And so these things can happen in glaucoma. They're still quite rare, but they're definitely more common in glaucoma, and that's why glaucoma specialists like to do, or we tend to do more complicated cataract cases. Again, this is going back to that same picture, that one of the benefits of doing cataract surgery is that you can relax, you can open up this drainage system. So again, the drainage system, look, if you look on the left side here, is in front of the color part of the eye. And so if the lens is pushing forward, one of the benefits of doing the cataract surgery alone without any other surgeries is that it will relax and sometimes open the drainage system, or sometimes we can go in and open it ourselves. So often I say the cataract surgery alone is beneficial for glaucoma, to take out that lens. And then while we're inside the eye, you can perform, like I discussed, something called a minimally invasive glaucoma surgery, which is basically going into your natural drainage system and trying to enhance it to make it work better. So you're basically removing the clogged front layer of the drainage system we call the trabecular meshwork. You use the same incision as the cataract surgery. It doesn't add too much time on to the surgery itself, and it doesn't add too much risk. And so we sometimes think we're already in the eye, might as well try to reduce the pressure. And so a lot of us will do it on a lot of our glaucoma patients. The other thing we should know is these procedures were invented at UCI and developed at UCI. I mean, we're fortunate enough, just to say this, I apologize if I put her on the spot, but Dr. Mosaid was one of the first people doing these minimally invasive glaucoma surgeries and brought them to the rest of the country. It was part of the first device that was developed, and that was developed here at UCI, as well as some of the stents, or one of the stents that was used as well. And so UCI, we're very lucky to be at UCI, where we pioneered this field and kind of know a lot about it. We know, and that's a blessing and a curse. And we know a lot about its weaknesses and its strengths, and where it plays an important role, and where maybe to avoid it. This is the first minimally invasive glaucoma surgery, which is still used today. It's still a very powerful procedure. It's called the trabectome. And so this gives a good anatomy of the eye. I like this little colored picture. But basically, this is the iris, the blue part of the eye, or the brown part of the eye. And in the very corner, in a circle, is that trabecular meshwork. And this meshwork is where fluid needs to flow through. And it's also the thing that can get clogged. And so we can take this little device here and remove that trabecular meshwork to allow more fluid to flow through the natural drainage system. And I'm going to skip the video here just for the sake of time, and we'll show a video of the actual trabectome in a second. But this is a video, or this is just the analogy that I like to use. So if you think of the drainage system of a sink with these little holes, not as much water can get through it. So basically what we're doing is trying to remove or widen this drainage hole in a sink to get more fluid to flow out of it. The reason that's important to understand is if you think of your drainage system in your eye as a sink, if you remove this front part, it can be extremely helpful if that's where the problem is. But if you have a problem further down in the pipes down here where the surgery is not touching, then it might not do anything. And so it's important to talk to the physician about that and realize that some people actually don't get much benefit from the procedure. And that's usually the reason why. Okay, so this is an example of what the trabectome is. This is the eye. Again, we're sitting on the side of the eye. That's where the instrument is going in. This is the top over here where the finger is, and down here is the bottom. And this device has a knife on the end of it and it also has some cautery. And so here you're seeing the trabecular meshwork, that covering of the drainage system being removed. And as it's being removed, you see that white shiny back, that white shiny thing following it in the back. And that is the inside part of the drainage system that's being exposed. So the outer shell is being removed, and that allows fluid to flow more freely. So this, of course, can be coupled at the time of cataract surgery. So this is a cataract surgery being performed, the lens is being removed, and once the lens is in the eye, then what we do is we put a lens on the eye so we can see into the corner. We often tilt your head off a little bit to the side, and then you can introduce the instrument. Again, this is the trabectome being used, and you can remove the trabecular meshwork is what we call it, which is that outer layer that prevents flow. And so you can kind of see how easily this is to be coupled with cataract surgery. We use the same wound, we sit in the same location, you go into that area, and it doesn't add too much on. This is another example of a different device. I just want to there's many different devices now. So this one is called the Omni, and it's used basically to do the same thing, just in a different way. And so as you see this device go in the eye, you'll see it has this blue catheter. And so it's almost like sticking a catheter down the drainage system of a sink. And you insert it in, so you can see it kind of going in right here. And then as you insert it in, it actually has a jelly. As you insert it in, as you retract it, it has a jelly that comes out and it dilates the pipes of your drainage system. And then the second thing you can do is after you stick it in, you can pull it out of the eye. And as you pull it out of the eye, it'll open up, it'll remove some of that outer layer, that outer trabecular meshwork. So you kind of do two things. So there was that was that jelly that was going in. And then now you're going to see the surgeon as they come out of the eye, that blue catheter will remove some of that outer trabecular meshwork. And so let's see, I might just fast forward here just a little. Oh, there it goes. So the whole blue part of the eye is inside the drainage tubes of the eye, but as you remove it, like it's being done here, it removes that outer layer to allow more flow. So cataract and glaucoma, there are increased risks. There are things to talk about with the physician. You have to manage the pressure at the same time, but it is an opportunity, and I think it should be looked as an opportunity. You have the opportunity of taking care of two problems in one session. These little procedures are very powerful when done in the right patient in the right way, and they can help the glaucoma a lot. But like I said, there are complications to watch out for. This whole area has been almost inundated by all these different products. And so they all pretty much do the same thing. At UCI, we try to avoid stents or something that you don't have to put in the eye, something that you have to leave in the eye in the drainage system. And so something like the trabectome works phenomenally, or the Omni device that we said that we just showed here. But you should definitely ask your doctor about the success rates of these devices and possible complications of them at the time of cataract surgery. I just wanted to end with a couple slides about the Gavin Herbert Eye Institute. I like Dr. Musa had mentioned at the very beginning, I've been here for about a year, so I'm relatively new, but it's a great institute. It has great programs, it develops technologies, clinical solutions. We have clinical trials going on, one of the premier sites in Southern California, and we're so lucky to have it in Orange County. The Gavin Herbert Eye Institute is nationally known. Like I said, there's clinical trials. There's constantly cutting edge research. As I said also earlier, a lot of the industry in the eye world is in Orange County. And so we're lucky enough to be close to them in order to incorporate that and to be productive with them. We have developed things like minimally invasive glaucoma surgeries in the past. We've worked with companies to start that. The femtosecond laser that we were just talking about was developed by a person that a researcher that was here. And as well as we've pioneered some of the stem cell research in retinal diseases. So it's just it really is a great eye institute. I can't speak highly of it enough. And again, I feel so fortunate to be here. As far as our glaucoma division goes, there's 4 glaucoma specialists here. They are all extremely highly skilled at complex cataract surgery and managing glaucoma and cataracts at the same time. I look up to my 3 colleagues a lot. We have all the latest, greatest technology. We do a lot of research. And it's a nationally renowned training program for fellows who want to specialize in glaucoma. And it has broad-reaching ideals and high standards of education and performance. So I realize I've talked a lot. Thank you so much for your attention. And thank you for allowing me to just be with you guys and present about cataracts and glaucoma. And I think at this stage, hopefully we have some questions in the chat box. So maybe I'll turn it back over to Dr. Mossad and we can read questions and go through.
Thank you so much, Dr. Smith. That was certainly very thorough, very exhaustive. So hopefully you've answered a lot of the questions as you went through them. But I'm going to go through the chat box and take some of these questions while you catch your breath, and we'll give you a little chance to bounce back. Okay, so the first question is, can you redo a cataract lens that has the wrong prescription? Wrong lens inserted for monovision is the question. So basically, what the attendee is asking is, if you put in an intraocular lens and it turns out that it is not the right power, and that sometimes happens, it's called a refractive surprise, can it be redone? The answer is yes. It typically can be redone and is best redone in the first few weeks after cataract surgery. The longer the new lens is implanted in the eye and stays there, it scars into place and it kind of becomes one with the capsule that's surrounding it. And so you really shouldn't look to try to take it out further down the road, because it's a much bigger surgery. You have to enlarge the corneal incision, remove the lens. Often the whole bag comes with it if it's been a long time since the procedure, and then your lens options kind of get tricky. You have to sew a lens into place. It's a much, much bigger operation than the original procedure. And so we generally say that if we get a refractive surprise, we identify it immediately. The patient is unable to tolerate that surprise and it's not something that they can live with, then we go back in and we swap the lens out really expeditiously. But if it's been there for a while, most surgeons would recommend to leave it alone and try to handle the refractive surprise with a refractive solution, such as spectacles, some sort of refractive surgery, laser surgery like LASIK or something like that. So generally leave it alone if it's been a long time. The next question is cancer treatment radiation, no matter where on the body that occurred. I think that the individual is asking, can radiation cause cataracts? And generally, no. The radiation that's done for cancer, if it's done not in the head and neck, anywhere else in the body, it will not cause a cataract. But even in the head and neck, in certain areas, it really should not create a problem. Having said that, if someone develops a cataract shortly after treatment for any type of cancer, a lot of that happens because cancer treatments are often heavy in steroids. Chemotherapy is often accompanied by steroid use, and steroids can cause a particular type of cataract called posterior subcapsular. They're all treated the same way. No matter how you got the cataract or where you got the cataract from, it's treated with the same type of surgery. It's relatively low risk and relatively high yield with good outcomes. And so really how you got it is not what's important, but managing it is. And if radiation is going to save your life, definitely don't avoid surgery. Don't avoid radiation just because of the potential for cataract development. Cataract surgery is typically a low risk, quick procedure. Okay, the next question is, do yellow lens glasses help with cataracts? They absolutely do not. And actually, your cataracts, as they develop, kind of function as a yellow tinted lens. They will filter much of the light out of your eye. The next question is, are the new cars' lights too bright? Will there be legislation to keep them less bright? I don't think anyone really has the answer to that about what's going to happen with the new headlights, but absolutely agreed with you. They're way too bright. Can cataracts come back if you do them? No, cataracts do not grow back. Once you've removed them, they're gone. However, sometimes, and in about 1/3 of patients, up to 1/3 of patients, a small film can grow on the back part of that bag that Dr. Smith was referring to as the capsule. We call it the capsule. A little film can grow on that, and that can be removed with an in-office laser procedure. It's very quick, very, very effective, and it can brighten up the vision right back to as good as it was post-op day one. And then that film cannot grow back again. And therefore, really, if you have a cataract surgery, you have a great outcome. In some patients, you develop a little film that can be easily lasered, and then you're done with it entirely, and you don't have to worry about that coming back. Let's see. Next question. I had incorrect intraocular lens inserted. Can this be redone? I think we already discussed that. Really not recommended if it's been a long time, but if it's within the first few weeks, certainly that can be considered. Next question. Are there ever any circumstances when both eyes are done at once? Yes, that is called immediately sequential bilateral cataract surgery. Many institutions are performing that routinely because of many considerations, mainly cost. It's one operating room anesthesia fee, and you get the problem managed in both eyes. If a patient has a difficulty in getting to the operating room, if they have some mobility issues or health clearance problems, it is something to consider. However, the drawbacks are that, number one, if you're trying out monovision or some other type of lens, you don't get the chance to see how the patient likes the first lens that they got. And oftentimes the second lens that they get is often informed by their reaction to the first surgery. And so if you need to introduce any kind of fudge factors for your lens calculations, you don't get that chance on the second eye. Also, there is a very small but certain risk of infection, and it would be devastating if that were to happen in both eyes, although the risk of that is very, very small. So in general, if you can make 2 trips to the operating room, it gives your surgeon and you a chance to really try out the lens that you got the first go round and see how you like it, and then move with the second. But certain circumstances certainly do allow for immediate sequential bilateral cataract surgery. Okay, next question. I had one eye surgery in which the cornea was torn horizontally, liquid oozing out. Sounds like they had a ruptured globe. Stitches required to repair. Even though it's been a few years, should I be concerned that if I had cataract surgery in that eye, it would be too much trauma? Okay, so basically, the viewer is asking about cataract surgery after trauma. And certainly, cataract surgery after trauma has a much higher complication rate because those suspensory ligaments that hold the cataract in the eye that Dr. Smith referred to as the zonules can be weakened. And so the risk of having any retained lens bits in the eye goes up. Not being able to have a bag that can support a new intraocular lens, the risk of that is increased. There are certainly much higher risks as far as complication rates for patients who have had prior eye trauma. Next question, can you remove floaters at the same time? Great question, Diane. No, floaters are in the vitreous of the eye, which is behind the bag that holds the lens. You would have to remove the vitreous, and that's called a vitrectomy, in order to remove floaters. And as a matter of fact, most people who have floaters will see them even more clearly after they have their cataract surgery because their visual axis has been cleared up. It's no longer cloudy from the cataract, and so they will perceive their floaters much more and will be bothered by them more. However, it's a matter of time before most people get used to them. I often say to my patients, make friends with your floaters because they're not going anywhere unless we do a major operation called a vitrectomy. Not worth it. Floaters tend to settle down depending on head position, lighting, and so on. They can be very annoying, I grant you, but it is certainly not something that's done at the same time of cataract surgery. Next question. And Dr. Smith, please feel free to bump in and interrupt me anytime if you have anything that you would like to add or subtract. Okay, next question. I have glaucoma. I have 2 drainage tubes in my eye. When the first drain was put in, they did cataract surgery, but after that, a bubble formed in the back of that eye. Can anything be done? Okay, a bubble can mean many things. I'm not exactly sure what the viewer is referring to, but what I'm gonna guess is that they're referring to something called a choroidal effusion, where if you have a drainage tube in the eye, sometimes it's working a little overtime, a little too well, and the eye becomes soft and can kind of pooch in on the sides and kind of develop into a little bubble, which can obscure the vision. And that is a phenomenon of pressure in the eye being too low. So that can be managed with raising the pressure in the eye, either by a surgical revision or what have you. But the viewer says they're reluctant to do cataract surgery in their other eye for fear that this would happen. And that, unless you have some sort of drainage device or pressure that's too low in your other eye, these bubbles typically do not form. So I would not be concerned about that. Next question. Are cataract surgeries done at the UCI campus, at the Gavin Herbert Eye Institute, or at the new facility? They are all currently being done at the Gavin Herbert Eye Institute on the campus of the university in Irvine, on the main floor, the first floor, we call it the ground floor. And so the only surgeries that are being done outside of the Gavin Herbert Eye Institute are if we have a very, very sick patient who is unable to undergo surgery on an outpatient basis, and they require some more monitoring and so on, then they're done at the main hospital and in the near future in the hospital at Jamboree. But typically, most of our procedures are done at the Gavin Herbert Eye Institute. Next question. I cannot lie relatively flat during surgery and get general anesthesia. Is the cataract surgery done in the hospital? So, okay, going back to that. Most patients who say I cannot lie flat actually can lie flat. Once they get a little sedation, we're able to position them such that the procedure can proceed. Cataract surgery cannot be done in any other position than lying flat. So it can't be done with you sitting up or whatever. So lying flat is really the only option. And that has nothing to do with whether or not that's done at the hospital or at the Eye Institute. But most people who say I have neck issues, back issues, we are able to accommodate it with all the different positions that the hospital beds can be manipulated into. And under sedation, most people are able to go forward with the procedure.
I'll add on to that. Sometimes our chairs at our institute will lay back. So in our exam room, sometimes if someone's concerned about that, I'll just lay them back as much as we can. Just give it a test trial just to kind of see where it's at. So we can also do that in clinic just to make sure we're all comfortable with the plan. But I agree with Dr. Mosai. Most people we're able to get flat and do it.
Thank you. Next question. I'm on 2 immunomodulators and dexamethasone. Is there any interaction? No, there is not. And typically the dexamethasone actually helps to keep any inflammation quiet in the early postoperative period. So no, there is no interaction. Next question. How do glaucoma stents work and how do they compare with the surgeries you described? Okay, the glaucoma stents are intraocular implants that are implanted into the trabecular meshwork, sort of like a little snorkel. It's like putting a little hole, punching a little hole into the trabecular meshwork with this metallic foreign object. And so basically, instead of opening up a large area of that drainage system, they just punch little tiny holes into it. How do they compare? The outcomes of most of these minimally invasive glaucoma surgeries are fairly similar. However, we tend to prefer non-implant based minimally invasive glaucoma surgeries, because implants, anytime you leave a foreign body in the eye, there is a risk of long-term complications related to having an implant there. It can migrate, it can extrude with eye rubbing, it can be manipulated to the wrong space, it can cause clouding of the cornea if it's too close to the cornea, if it was implanted inaccurately, and many of them are. It can cause long-term deterioration of the cornea and other structures. So we tend to prefer other types of MIGS, but of course, many hundreds of surgeons, cataract surgeons, use the stents, and patients do very well overall. Who is the top glaucoma cataract surgeon at UCI? Well, I would have to say there are 4 glaucoma fellowship-trained glaucoma surgeons at GHEI, and all of us perform cataract surgery. In fact, we tend to perform the more complex of the cataract surgery, since the comorbidities, the other eye problems that we manage, tend to make the cataract surgery more high risk. And I would have to say that I would trust my family and my eyes to any one of these surgeons. So again, I would let Dr. Smith operate on me or any of my family, and I would trust any of them for sure. Let's see. Next question. What about pseudoexfoliative situations in glaucoma? Okay, so the next viewer is asking about a particular type of eye condition which increases the risk of glaucoma. It's called pseudoexfoliation. And what that does is it does make those suspensory ligaments of the cataract, the zonules, much weaker, and it clogs up the drainage system of the eye. Patients with pseudoexfoliation can have up to 10 times the risk of complications during cataract surgery. Having said that, all of us are trained in how to manage these types of patients. So we really deal in the art of anticipation and kind of anticipating what problems we're going to face. And so we do a lot of pre-surgical planning. And so the vast majority of patients with pseudoexfoliation do not have any complications during surgery, and the procedures do come out great, but it is good to be aware that it certainly does have a higher risk. And having said that, we often will recommend cataract surgery a little bit sooner in patients who have pseudoexfoliation. So we may not wait until the patient really feels very impaired by their vision, because the longer you wait, the weaker those ligaments get and the higher the risks. But of course, that has to be weighed with the patient's current vision and their current functioning. So it is, again, a conversation that's very individual. Doc, did you want to add on to any of these comments? I think we've
Well,
come to the end of our questions.
that's great. I mean, I'll add on to that last one. I think pseudoexfoliation, we talk about killing 2 birds with 1 stone, and they tend to respond pretty well to the minimally invasive glaucoma surgeries. And so it's as much as it's maybe a more difficult surgery, it also can be extremely beneficial for people with pseudoexfoliation. So it's a good opportunity. But other than that, I thought those are all great questions, and I think very well covered. Thank you.